Moderator.
Thank you very much.
Thank you so much, Natalie. Thank you, everyone, for coming tonight. I'm really looking forward to the questions that we have, which I think are just interesting. Plus, I do know that there will be real CME material in here because there's some interesting stuff going on. I did revamp the questions slightly, but don't worry, it's all the same material. We're just combining a couple of things. But let me start with just each of you taking a minute to introduce yourselves and let us know what your area of practice is and your relativism to men's health. Thank you. I'll let you go.
My name is Dr. Kyle Adams. I'm a family medicine physician. I work for UC Health at an outpatient clinic. My interest in men's health is pretty broad, given that I'm a family physician. A lot of patients will start at their primary care doctor for questions and concerns and kind of branch off from there. So.
I'm Dinesh Twang. I'm a urologist. Most people think of urologists as being men's health physicians, although we do treat the spectrum of all ages and both sexes, but specifically problems with sexual function, erectile dysfunction, prostate-related issues in terms of what is probably most on the forefront for what you guys would think about, or I expect for us to have those conversations today.
Thank you. I'm Michael Barber. I'm a cardiologist and an electrophysiologist. And I'm not sure how I ended up on this panel. I'm a little different. I do more integrative cardiology. I'm a recovering traditional cardiologist, and I'm now more of an integrative cardiologist.
And I did forget one other little quick question in the beginning was if each of you could just give us an idea, like what proportion of your practice or the patients that you see are men?
I would say about 60 to 70% is men for me personally.
In my case, it's a little bit different. I have traditionally seen a lot of men in the office, but now my practice is quite a bit split. I'm one of the only urologists in town who deals with female urology and pelvic health problems, prolapse, and that type of thing. So I see a mixture of everything.
Okay.
I'd probably say I'm pretty close to 50-50.
Great.
To be honest.
Okay, well then, let's get to our first question. And I'm going to ask the question of all of you. I think there is time for each of you to give a response. This question regards, cardiovascular risk, which of course involves other things such as, for example, erectile dysfunction, metabolic health, even possibly sleep disorders. So, many serious health conditions in men, such as heart disease, diabetes, hormonal imbalances, they don't really always announce themselves with dramatic symptoms. And maybe we all think, I don't know, maybe we don't know whether or not men come to you until they're more dramatic. So, maybe they're showing up with fatigue or weight gain or libido issues or erectile dysfunction or even sleep disturbance. So I'm wondering if each of you can share, what kinds of early warning signs do you really look for? And how are those symptoms kind of connected in terms of what you deal with in your specialty? May as well just go with you first, Kyle.
As a family physician, I usually run into a lot of these types of questions. These are things that we have to think about a lot the minute the patient comes in with specific complaints, and they do tend to be pretty vague sometimes. That would trigger us to maybe think about a cardiac cause, things that like fatigue. I have a lot of patients that are younger, like to exercise. Suddenly they're not able to lift as much weights as they're used to. And it's sometimes it's drastic, sometimes it's not. Other things such as libido, erectile dysfunction, less sexual drive, some weight gain, that they're unexpected given their no drastic changes in their diet and their continue to exercise. And then sleep disturbances that can trigger things like checking for obstructive sleep apnea, And then also just generalized, just decreased stamina. I feel like I'm getting older than I should be. Those are all sort of symptoms that patients come to me with that triggers, let's maybe think about the cardiovascular aspect. So
I think as a urologist, I'll see a panel of patients, or I'll see patients for either because they were primarily referred, or they may be referred by someone like you, or they may come in on their own or at the urging of their partner. More often because of the urging of the partner when it comes to men. And probably one of the first questions I have for men who complain of problems with erections or sexual dysfunction or decreased libido, less interest in sex, is when was the last time they had a physical? 25% of men over 40 will experience some form of sexual dysfunction or problems with an erection. So it's not an uncommon problem. It can be episodic. It can be totally unrelated. It can be related to fatigue and other stress and other things that can happen. But I tell them that the arteries, the cavernous arteries, the little arteries in the penis that are responsible for blood flow to the penis are much smaller than the ones in their heart. And so if they have not had a physical and have not talked to their primary physician and have not had cardiovascular screening, then that's one of the first things we tell them, kind of the canary in the coal.
I probably have a pretty skewed population compared. A lot of people are referred to me specifically with the question of, do I have a cardiac problem? Interesting little change is I'm seeing a lot more 40 and 50-year-olds. And the predominant reason in most cases is they've had someone in their age group have an event who ignored exactly what's been discussed here prior. So that's a nice shift to be able to get in and be a little more proactive. I get a lot of referrals they have abnormal lipids, have abnormal blood pressure, and they just want to get checked. And I take a little different approach than a lot of the general cardiologists in that a very deep dive into their labs. I think that's very important for some of the screening, and I'm sure we'll get into that as we talk later.
Okay. Thank you. Okay, so I have two follow-up questions related to this, and we still have time. One is, you mentioned that great pearl about how the blood vessels in the penis are so much smaller. So in fact, it's like a great early warning system in a way, right? And I think that's a great pearl to share with the patients because make them feel like, oh, well, this is a good thing that we're catching this now. So then I guess the question is, how much are you seeing this in people under 40? And the other thing is especially for family doctor, how often do you see that chief complaint and immediately think about you might want to order labs, check cholesterol, whatever else it is? You want to just talk a little more about like what your usual approach looks like?
If we do have the patient coming in with the concern about erectile dysfunction, we look at the patient's age. That can kind of help stratify the differentials for it. But we look at we do basic lab work, check for hormone causes, things like the testosterone levels and things like that. We do a pretty extensive kind of a history. Are we able to get erections at all? We have the nighttime erections or not? Is there we have to screen for psychological causes as well. Those are the kind of the things that we start with, especially in younger populations under 40, where the risk of cardiovascular disease isn't quite there.
I think along those lines, I'm not a psychologist, but I'm married to one. And, the younger population, especially here, just because of a significant military population that we have, there's a lot of PTSD, a lot of relationship problems and issues. And so I try to ask questions about kind of what their whole, what their experiences are and what do they do on a daily basis and how do they get along with other people. I find that to be something that is probably, it's a good opportunity for me to refer people. But it's also another type of screening thing for other problems, issues.
And I would support that. I think a very lost art in our profession is the history and physical. I can't tell you the number of people that I've seen. They say, I've never had that done to me before. Well, it was good. It wasn't anything bad. But so staying within the boundaries of ethical practice. But I think that that's a really underappreciated, and listening to the patient, talking to them and examining them. And we don't do that anymore. There's a gentleman right here that taught me a very valuable lesson early on in my career, and about taking a good history. It's not cardiovascular related, but really quickly, I admitted a patient that was having an anterior wall myocardial infarction and interviewed him. I thought I did a pretty good job on talking to him, and his wife sat right there while I was talking to him. So we got him through the heart attack, and about 3 days later, he's going nuts. He was into real estate out in South Park, and they were selling those 5-acre lots to Californians, hand over fist. And I had asked him, I said, do you drink alcohol? He said, well, I have 1 drink a night. So I was just busy as heck. I got an internal medicine consultation from Dr. Wall. And he comes out a little later, shaking his head. He said, I'm going to tell you 2 places you screwed up. He was very nice about it. He didn't say it exactly like that, but 2 places where you screwed up. He said, first off, this guy's Irish. Second, you only asked him how many drinks. You didn't ask him how much. This guy was doing a 16-ounce tumbler of vodka every night. And he was in DTs, classic, and he reinfarcted. We got him through that again. But I learned the value of really taking a second and saying, okay, now what does 1 drink, and I'm smarter now, a pack of cigarettes means 2, and 1 drink means 4. So I'm doing better, but the importance of the history and physical.
The devil is in the details. Yes, I got taught that good history stuff too. So real quick, so what kind of percentage do you think, and there must be data, but there's also your clinical experience, with erectile dysfunction in particular, what percentage is psychological factors versus, or, fatigue, stress, that kind of stuff versus actual vascular issue?
I would say when it comes down to it, and in my practice population anyways, if I'm looking at, I guess we can split it up into less than 40 or over 40. The less than 40 population, it usually is more of a psychological component to it. Probably a good 90%. There are, there's another 10%, their testosterone hormone levels are just super, super low. And we try to correct that. But above the age 40, I think the diabetes, medications as well is a big part that patients don't realize that can cause those types of symptoms. And then the cardiovascular and the hormone component of that as well. Probably again, it's just split. Probably 90% is that.
I would add in the younger population, substance abuse. As a big one. People don't really correlate alcohol use with ED, sleep disturbance, diabetes. Smoking is terrible. And, just in terms of what it can do to you in terms of your cardiovascular health, you probably speak to that much more than I do. But and I talk to them about bladder and lung malignancies and other things that we see. And as men get older, it's common. And I think one thing I try to do is reassure them that it's common, that there are other things and lifestyle things and other health issues that they need to be aware of. But it's not anything to be embarrassed about. It's given us an opportunity to improve their quality of life and maintain their relationships and maintain their sexual function. So I think there's a lot of opportunity there.
Good.
I probably have the least experience because I try not to ask them. But in my arena, obviously, medications. So many of these people are on medications for blood pressure, for lipids. And then my population is skewed more towards being older. So hormonal effects, I look at that very strongly. And then cigarettes, tobacco.
Very helpful. Thank you for that. And we've kind of segued a little too, because Dr. Adams mentioned about, especially in the younger group, you got to check their hormone status. So testosterone is a big topic of discussion in men's health. There's, of course, we want to help everyone here tonight to sort the wheat from the chaff, as it were, in terms of, the patient-driven demand and the misinformation that's out there. And, we see these clinics even popping up all over the place as if there's just one answer for everything. And so talking about things like testosterone replacement therapy, what is the evidence really? When do you really need to test? When do you really need to treat? What are the risks? How much does it really affect things like sleep or weight or their muscle mass or whatever it is in your experience? So, what does it take for you to want to write that prescription?
So yeah, this is we do have a very high military population, young men coming in because they don't have the energy that they thought they did. They have the decreased libido, the weight gain, some the erectile dysfunction, and then even sometimes like infertility and things like that. Older populations, we have the risk for osteoporosis, and then low trauma fractures, things like that. Those are kind of prompt me to think, well, maybe it is a testosterone issue. Other things like type 2 diabetes, the obesity, if they're on chronic opioid use, glucocorticoids, things like that. Sleep apnea is another very, very big one that we run into. And those can kind of make me think, well, maybe we need to check those hormone levels. Now, when we have someone come in that just says, hey, can you throw a testosterone on there? The first thing I say is like, wait a second. Let's see if we're having any symptoms or not. Because in my experience, and in a lot of studies have shown that if you're not having symptoms of low testosterone and you supplement with that testosterone, generally, you may get a little bit of boost for a little bit, but over time, you lose the effect. And that on top of, I try to educate the patient on the risk of testosterone use as well. There's a lot of mixed data out there on, the risk of testosterone replacement, but I just try to give them the best education on it as I can. But when it comes down to it, I really try not to test for it unless they're actually having those symptoms. And I wouldn't imagine treating it if they didn't have the symptoms either.
I would second that. I guess I think of it as, is it the chicken or the egg? Is it, and unfortunately, they if someone comes to me and they've had a testosterone checked and perhaps it wasn't done first thing in the morning or early enough in the morning because it's a diurnal variation, you have a circadian rhythm with testosterone. So there are appropriate times of day that you're supposed to check that. And it doesn't have to be fasting, but I guess there's two perspectives. One is chicken or the egg, is which one's the first problem? And the second issue ends up being the concept that testosterone will fix everything. And unfortunately, especially with kind of the entrepreneurial spirit of the low T centers and other places that you can see where, their main gain is to just sell people testosterone, and they'll tell them that they need to have a testosterone of 800 to 1,000. And particularly in this climate, I practiced in Michigan forever and rarely saw polycythemia. I see it all the time here in patients who are on testosterone replacement therapy because it's inappropriately dosed, inappropriately managed, not followed. And then because of the altitude here, the elevation causes polycythemia. So we see that quite a bit.
I would second that. One, symptom driven, again, history and physical. Two, polycythemia is a big deal. And probably 15 years ago, I would not have written a prescription for testosterone. I've softened a little bit on that, but I agree. This needs to be managed well. You go to these low T clinics, and it's the old saying, when you're a hammer, the whole world looks like a nail. And that's what these low T clinics are. And I've had a gentleman that's still not very happy with me, but he was in a low T clinic, and he was at 1600, and had a hemoglobin and hematocrit off the charts. It's lucky he hadn't had some sort of an event. And so you also get a lot of grief when you try to cut those people down. I know you guys probably deal with that more than I, but that's, you're trying to educate and you're doing the right thing for the patient. And, you know, they're being told by somebody else that you need to have this and just need to be cautious and educate.
We've actually had to institute, just like for opioids, if you're managing opioids, you have contracts. We've had to do that with testosterone for the same reason. If you're not going to follow up and if you're not going to get your lab testing, if you're not going to do the things that we think are appropriate, and it's because it's been that big of a problem.
You feel a lot better at 1500.
Their family members might be a little upset with them at times, but roid rage could be a problem. But yeah.
I have a prime example of just what you guys were hitting on about, following with the low T center. I have a lot of patients that come in to establish care. Like, oh, you're on any medicine? No, they're on a medicine. And then I look, and sure enough, they're on testosterone. And I start to inquire about, how long have you been on it? What have your levels been? What are your goals with that? And, sometimes they know, sometimes they don't. I have an example of a gentleman came in, 55 years old, type 2 diabetes. You could tell that he was on testosterone because he had the big muscle body and things like that. And he was feeling great. And I love it. And I told him, I did some lab work on him. I had him back a couple of weeks later. Said, you have to stop this testosterone. Your hematocrit's 1920s. Your testosterone level is 1200. I've never seen a natural 1200 before. This is not going to be good for your heart. You need to back off on this or stop this. And he was adamant that he was doing great. I got a notification a month later, AFib and heart failure, heart attack in the hospital. Saw him back 2 weeks after he left the hospital and saw me, and we talked, and he's like, when can I start the testosterone again?
Oh yeah.
And I said, no, never. But I feel so weak. I want to go back to the gym. I love the gym. He probably spent 3 or 4 hours a day there. Like, no, you're going to have to do it without it. And I've continued to follow him, and he followed my advice, and he's doing great. He feels great. He's not as big and bulky as he was, but he exercises, and he's fine. So, I see that. That's not the only time I've seen that exact scenario where they end up in the hospital because they didn't quit. So. It is a real thing.
I'm sure you can probably quote it better. I can't remember the name of the study, but it's the 2023 study looking at testosterone replacement and were there cardiovascular complications of testosterone replacement, and there were few, but for the most part, it was felt to be safe. But it was also just topical testosterone, and they were only replacing the mean patient testosterone was 450, where it's supposed to be. And when you start overdosing and all these complications that we see are going to be a lot more common in patients who are expecting a much higher testosterone or dose, or not following up as appropriate.
Tell my patients, I'll give you a T-shirt that says, I'm not on steroids, but thanks for asking. So I think that that's the approach that I like to use. And I agree 100%. You have to monitor it. And that's where I go crazy when I hear these commercials on the radio or wherever, because it's not a cure-all.
No. Wow, thank you. That was really useful information. It is a societal problem too, right? That people always think there's something else they're supposed to be doing. They can't just be happy the way they are. So we have to help encourage our patients. The health is the important thing. So the next big subject, of course, in a men's health discussion is prostate health. So we really are still, I think, confused sometimes about navigating screening and whether or not people need to be referred and when, whether or not people still need digital rectal exams, all of it, right? It's all been controversial. Guidelines have been changing. Patients are confused. Some doctors are confused. I remember being at a conference one time when they told us, okay, you don't have to do PSA anymore. But then the guy said, but like, wouldn't you do it for yourself? And everybody raised their hand, right? So, yeah, let's start with you, Dr. Slang, about what you think about, approaching the PSA conversation and how you make your decisions, and when should a primary care physician sort of get you involved?
So it has been kind of a lot of changing information, I'll say, over a long period of time, in terms of what the prostate cancer prevention trials and what the now I'm forgetting the name of the healthcare USPTF. Yeah, I hate that place. Anyway, prostate cancer is very common. We have 168,000 something men diagnosed every year, despite all the screening. We keep finding them. Prostate cancer, lung cancer kills more people than prostate cancer because you have two sexes. But prostate cancer deaths have been on the decline since we started screening for prostate cancer. And we think that's a direct effect of early detection. What's appropriate for early detection? Well, certainly anyone who doesn't have at least 10 years life expectancy shouldn't be screened. I think, the problem is patients get an expectation that you've had a PSA every year, I'm 85 years old. Why are you not doing my PSA? Well, you have to come up with phrases that make sense. So for example, you've taken that test for 20 years, you've passed every time, you don't need to take the test anymore. You have to have something else that rings true to them that doesn't necessarily say, well, because someone else told you not to. When President Biden was diagnosed with metastatic prostate cancer, I had two thoughts. One is you don't typically screen men in their 80s for prostate cancer. The other thought I had was he has a really crappy physician who never did a rectal exam.
Yeah.
And he's the president of the United States. And so prostate cancer screening might not have been appropriate from his health perspective. But when you're leading a country, I think you should know the health. You should know the health of your leaders. That's important. And that's just one health issue. Mental status and everything else could be another one. But so think of when we talk about shared decision making, and I feel for primary physicians because the rectal exam. When I was in med school, there were two reasons not to do a rectal exam: no rectum or no finger. And
I like it.
And it's a lost art in terms of doing. I think it's just part of the physical exam and the decline in the ability to do physical exams in physicians in general. You have to do a CT scan for appendicitis. Like, I used to know how to do that because I put my hand on their belly. So I think, and doing a rectal exam, I talked to my primary physician years ago. I said, do you do rectal exams all the time? He said, yeah, I do. He said, because you're my patient and I'm your patient. Meaning he didn't want to admit that he wasn't going to do it anymore, but he said it takes time. And so when you're a primary doc and you have a list of 32 things that you have to evaluate, that is one thing that does take time. And so I understand that if you're going to do it, then do it regularly, become facile at it. What I disagree with is that there are a lot of urologists who don't do rectal exams. anymore. And, this talk about how uncomfortable the exam is and how demeaning it is. And I'm thinking to myself, women do pelvics for their stuff all the time. That's a lousy excuse. But that's my personal bias. And certainly PSA testing is appropriate, especially when you have a family history. We see more familial prostate cancer now than ever, and that if I see an abnormal PSA other than the normal rectal exam, that history will change my evaluation paradigm because I'll look a lot harder if they have a family member who was under 70 at the time that they were diagnosed. But we see people all the time. I have 2 uncles and my father and my brother. We see that on a regular basis. And just like breast cancer, the BRCA gene is just as important for prostate cancer as it is for breast cancer. And so that genetic component of the disease is also something that I pay a lot of attention to. I want to take up all the time.
Am I allowed to ask a question?
Yeah.
Okay, I'm a simple country cardiologist, so like to just know, do you vary your PSA level and recommendations based on age? I'd read some things about at the age of 60, less than 2.5, over the age of 60, it bumps up to the 4. What are your thoughts on what I should do with a PSA and based on age?
The concept of age adjusting PSA or age appropriate PSA came out of the Mayo Clinic probably 25, 30 years ago. So it's all related to white men in Olmsted County for the most part. And so it may not always be applicable. I use it to my advantage, meaning if I assess a patient and I think that, not my advantage, but I should say to the patient's advantage. If I see an older gentleman with a really big prostate gland, because I examined him, and the PSA is just mildly elevated, there's the concept of PSA density. And the idea that PSA is elevated in prostate cancer is that PSA is a protein that's just made by the prostate. It leaks into the bloodstream in most men who have a prostate to a certain degree. And there are several things that can cause a PSA to be abnormal. Prostate size, the bigger the prostate you have, the higher your PSA will be, which is why as men get older, the prostate's the only organ in men and women that actually grows, like you get new cells over time. So your PSA will rise over a period of time. There is an appropriate rise over time. So a change in PSA, or I get referrals, about a change in PSA, which is appropriate. If it's more than 0.5 per year and you have 3 different documented levels, then that might also be an indicator that there could be something abnormal, or it may promote or recommend that we do something more. So I use it, but if I say, you have a huge prostate gland, your PSA is only minimally elevated, you can just watch you. You don't have to do a biopsy. And there are a lot of newer things like MRI where we can look for higher risk prostate cancer. Hopefully, if you have a normal MRI, maybe we can not biopsy you with the understanding that there's a lot of men out there with low-grade prostate cancer that'll never die from it. We don't really necessarily need to know that. So I use it probably more on the upper end than on the lower end of things.
I have a good friend who, 75 at the time, and had just a minimally elevated PSA. Prostate was biggish. Saw several urologists in the Springs, and they all said the same thing. We don't need to do anything. He's one of those that, boy, it's cancer, it's in there. And he found a doc down in Florida who would do the surgery. Right. Well, so that's how, okay.
Yes.
I didn't know. That's where he found him. And I counseled him. I said, I don't really think we need to do anything. Let's just keep an eye on you. And he was one of those that it's in there. I want it out. He's impotent and incontinent. Got a complete prostatectomy and is impotent and incontinent. So I had I never said I told you so, but a real respect for the urology community here that he trolled. He went looking several places and couldn't get anybody that wanted to operate on him. And I thought that was reasonable. And I guess it turns out I'd rather have a little bit of a big prostate than incontinence. And
No,
Yeah.
it's a race. We're all going to die of something. It's what will kill you first. And most men, if they have, especially low-grade prostate cancer, men don't die from low-grade prostate cancer. So if I can avoid making that diagnosis, happy to.
that's right. So I'm trying to get you,
Mhm.
other than this.
Correct.
And
Yeah.
just couldn't live with that.
Yeah, and then there's also the concept that our treatment changes on a regular basis. And so, I came from Michigan. We had something called the Michigan Urologic Surgical Improvement Collaborative, which was Blue Cross sponsored. We looked at prostate cancer care, and we looked at staging, trying to decrease costs, trying to reduce the risk of biopsy. We also looked at active surveillance, and we're actually able to dramatically raise the amount of number of patients who were being followed with active surveillance. The concept that we know you have cancer, but we don't think it's going to be a big risk to you, and there are ways that we can watch it, not necessarily treat it. And when I talk to patients about that, it's not that we're telling you that you can never get treatment. 1 out of 3 patients would ultimately get treatment within 3 years. It may change. But if you can avoid the risks, the complications, the side effects, and what I can't predict is I don't know what the best treatment for prostate cancer might be 5 years from now. And so you might not be getting side effects, risks, or complications of something right now, and you might be spared that by some better treatment that we have in the future. There's a lot of different ways you can try to make that type of thing palatable.
Right. Dr. Adams, anything to add to this? I know you probably have this conversation often.
Yeah, when just in our annual physical exams for male patients, one of the top questions is, hey, why didn't you order me a PSA? Where's my PSA test? And one of the things I really try to determine is, we try to look at risk, how old the patient is, family history, like you said, genetic factors, race is another one as well. African Americans definitely at a higher risk for prostate cancer mortality. But it's not a one size fits all screening test. I really try to do some shared decision making, kind of discuss the risk of further testing that can come about an elevation. And then, if there is a persistent PSA abnormality or an exam where I feel that the prostate is irregular, that's when I'm pretty quick to refer to try to get that diagnosis, because I feel like when the patient has all the information, then they can decide, do I want to go forward with the treatment, or is it something that I can wait on? Lots of times I'll tell the patient, screening can help detect the cancer early, but it also finds cancers that may not cause any harm at all. And so, it really just depends on, their longevity as well. Do I anticipate this patient's going to live another 20 years? They're 70 now. Well, probably go ahead and treat it. Get it taken care of. Or we can continue to test. So it's not it's not really a strict guideline that I follow. I just try to educate the patient. There are risks with treatment as well. The impotence, the urologic issues, and just because somebody has success doesn't mean it's going to be 100% success for you. So.
I think that's a good point raised about, really the importance of discussing with the patient and assessing all the factors and including future risk, et cetera, and lifespan, all of it. And this is a good segue into our next question, which is, talking to men about these kinds of things. I think we all maybe have a feeling that it might be a little bit different than talking to women about some things. And certainly when it comes to depression or anxiety or emotional issues or mental health issues with men, especially if you don't always get that, what did we used to call it? The yellow ticket. They'll come in with one complaint, but really they're there for another reason, right? And so, how do you guys, I'm going to again start with Dr. Adams because he's family practice. How do you create space in a time-limited visit to be able to give somebody a chance to open up to you about something like that could be going on?
Well, a lot of times mental health with male patients can be fairly taboo. They don't want to talk about how they're feeling, their emotions, things like that. So I try to, in a roundabout way, just ask about how their life's been the last few months. I have a pretty good rapport with my patients to begin with. So a lot of times we just talk about life and things are going. And I'll do simple questions like, how's stress at work? How's the trip you just had? Have you had time to yourself or do things that you enjoy? And those can be kind of segues. How's the relationships at home with the wife or kids, things like that. And they're fairly forthcoming with oh, not so good lately or this, and then that can kind of help me kind of get an idea of where their mental space is. If they come in with a chief complaint of maybe they're feeling more tired than usual, I'll start to ask about things like, well, are you having anything new, like any headaches, back pain? All those sorts of things can be kind of signs that mentally they're not in the right space. And then from there, it's really, I try to, because there is such a taboo on, I'm not going to tell, oh, are you feeling depressed? Are you feeling, poor concentration? Is your libido down? Is your sleep okay? Are you well rested? Have you been working out like you usually do at the gym, or go for you've been skiing recently? Things like that can give me a sign that they may not be as well either.
So there's no secret football lingo for I'm having a problem? No? Anyone else care to comment on this topic? Because mental health is part of all medical care, right?
I have a little bit of a luxury in that I don't have as much of a time limit on my appointments. And one of the things that was good about COVID, but bad, we evolved into telehealth. And body language, to me, is so crucial. All the things you're talking about, you watch their change, their demeanor, what happens to their, where their arms are, what their face looks like. You mention a family member. So I, again, don't consider myself exquisitely intuitive, but there are keys there that we just can't get on a telehealth or on a video visit, in my opinion. And that's why I feel the face-to-face is always crucial, especially if you feel you need to address that component.
And other things too, like I said, you don't want to necessarily the idea of mental health and things like that. Like, oh, it's depression, but you kind of connotate it to, well, yeah, it's like anything else. Like, it could be like it's very common. It's like we treat it just like we would hypertension or heart disease, diabetes. There's a ways that we can make things better. So that helps a lot too.
I would say that men seem to be much more open now than maybe they were 10 years ago. I don't know why that is. I don't know if it's the aging of the population along with me, or if it's and I see a lot more couples coming in to appointments, both men and women, which gives you some context, especially for sexual dysfunction, for example. Guys like, I want Viagra and wife, or the other way around, and their teams seem to be much more open about it. So I think, in terms of just openness, I think perhaps it's easier now than it had been past. If it is, I don't know.
Thank you. All right. We could probably do one more quick question, and then I think we'll open for questions from the audience. So the last question relates to, again, the modern world, the world of Dr. Google, and God forbid all the AIs that are out there now. I've certainly had the experience myself where sometimes it's extremely useful for a very complex patient to come in and have AI have already sorted out all their symptoms and given me some ideas of what to look for. And I generally try to handle it fairly graciously. But I think we do want to know, I'll start again with you, Dr. Adams. Sorry, I keep picking on you, but I wonder if there's a little bit of a difference with how men versus women handle this, in terms of when they bring you the info, what their expectations are. Are they really sort of expecting you to just confirm what they've now self-diagnosed? Or, are they really getting into trouble with misinformation? What's been going on there with you?
I really like this topic because I think in the internet age and how rapidly communication can happen with social media and things like that, the advent of the podcast. I have a lot of patients come in and say, "Oh, well, I heard on this podcast or that podcast." I'm not going to say specific names, but they told me that there's this. I need to get this test done, or I need to get this lab test done, and I need to be on this supplement and that supplement. I try to first educate or ask questions about, well, why do you think you need this? And lots of times it's, well, because they said that it's important. And I said, well, let's tell me more about these people that you heard this information from. I try to identify the source, put that in perspective for them. And then try to give them the honest, is there really, what are these studies that they're talking about? Can bring to light, the validity of these studies. It takes time because a lot of times it's very hard to convince people that have already made up in their mind that this is what they want, this is what they think that they need. So I try to combat that with the knowledge that I already have. I try to direct them to more reputable websites, maybe more reputable sources, and then there's I try to do different things like try to connect the information. I try to tailor it to their lifestyle and their goals, and try to show maybe a safer way or a more evidence-based way to get to that goal as well.
Mm-hmm. Yeah, actually, that's sort of our advantage now, I think, with the AIs, that we can have the comeback of, oh, okay, well, let me look this up with you. And then you can start reading them some of this stuff. And sometimes that works too. Anyone else want to?
Yeah. On that, I'll actually have them. I'll bring up the website or the stuff that they're looking at, and we'll say, well, let's go through this together, and I can tell you, and I can show you where this makes sense or this doesn't make sense. So that's very beneficial too.
Right. And then the last question after where did you hear this from is, were they trying to sell you something? Right. Dr. Barber?
I was just going to say, I think one of the points you made, whenever you can come at a patient and use the term evidence-based, that you've dug into it and can really look that there's science behind it, that there are very few supplements that cure heart disease, and there's very few supplements that are going to make your Johnson stand up. You've got to really look at things. My wife gave me a wonderful cup that I now have to hide, but it says, your Google search does not supplant my MD. And it should not top that, I don't think. So I really try to come at it from an academic standpoint, not humiliating them, but very gently, sometimes not so gently, saying, where did you get this? What makes you think that this person who's trying to sell you something is better than what your primary or what I'm telling you?
I think that's very important to recognize that the patient they do have a lot of times they have their mind made up that they want something, and then tell them I really try to show me the evidence that this works. The evidence may not be there now, but maybe in the future there may be something behind that. So I don't want to dismiss it completely, because lots of times that patient will eventually they'll go to Florida and try to find what they want. And my end goal is to keep the patient safe, even if it's from themselves.
I've taken a little bit different approach, I guess, maybe at times. Because they usually launch right into what they want.
Yeah.
And so I said, well, wait. I just say, before you tell me, why don't we step back a minute and tell me what's bothering you? And why were you looking at that? What what symptoms were you having?
Right.
You know, let's start a little bit more basic and then kind of go from there, and we can see what's appropriate. And that's usually been pretty successful. I mean, we had a patient last week who didn't want blood because of mRNA vaccines. And, you know, I'm not going to dispel their problem with mRNA vaccines. But what I can say is, if you don't want blood, are you willing to die? You know, because, you know, I asked if there's a religious objection, or you're a Jehovah's Witness, you know, you have a specific reason. But if that's your reason, do you feel that strongly that you'd rather die than get blood? Because really, we don't like to get blood unless we think you're going to die without it. So she changed her mind. You know, I think you sometimes have to give them some perspective.
Well, I want to thank you all. It was just a tremendous discussion. I think we actually got quite a bit of CME in here, didn't we? It was good. We do have a few more minutes. Does anyone out here in the room have questions? Yes.
Yeah, one of the common things I heard through all of your discussion is it takes time. Research and physicals, rectal exams, psych, preliminary evaluations. How do you balance that with your schedule?
So just to repeat the question, the questioner is asking about how so many of the comments involved that things take time. You have to discuss with people. You have to do a thorough history and physical. How do you handle that?
Well, it starts with that physician-patient relationship. You know, when a patient first comes in to establish care with me, I really just try to set what their expectations are and where I stand on their care, and the trust. You know, once, and that can take some time. Sometimes it's a couple of visits. I get the luck of I have a lot of follow-up with my patients because I'm a primary care doctor. I don't, you know, I'm not a specialist. So, you know, most specialists, they'll see their patients once or twice, and that's it. So I have that at my disposal. You know, I try to mix my schedule up, you know, with patients that I can flag them with my staff that this patient is going to take a little bit extra time, or so I can spend a little extra time with that patient, and then, you know, catch up with the shorter procedure patient that I may have coming up next.
So does UC Health tell you what allotments time are?
No, they don't. And that's something that I like to take to my advantage. I like being able to move the clinic along, and, you know, I'm big on getting my staff out on time, but I always dedicate every patient needs a different amount of time, and I tell them if they interrupt themselves, say, "Oh, I'm sorry, I stop and say, no, I will take as much time as needed with this," so that they like hearing that as well, because they know that I take them seriously, and again, that builds that trust relationship. So when I do say my short little spiel to them, they trust it. So
I think I have the luxury of being a specialist, so that sometimes helps. But there are times when I learned this from one of my old attendings years ago. You know, come in with too many complaints, you just say, "We only have time, you know, pick your top 2 or 3 or whatever it might be, and then we'll really look at those things, and then we can set aside time another time, because I can't fix all those things in once. I wouldn't do a good job of that. I think in terms of time allotments, we make our own templates and schedules where I'm in UC Health as well, so it's not an issue. I find myself, if things are running late, you know, people need time, they get time, and I just apologize, and I don't wear a watch in the office. So, you know, someone says, "Do you know what time it is?" I'm like, "No." You know, like, I'm here, let's talk, and you have as much time as you need.
Do you think
So-
that's affecting your ability to see patients over a period of time? Because, the most frequent thing we hear now is, I called and it's going to be 3 weeks before I get in, 3 months.
Well, that's a provider shortage problem. I mean, I think there's
Could be.
when I came here 3 years ago, I was a urologist, and 4 years ago now we're 7 looking for 8, and the 7 ABPs at 1.
I think I think template management is the key. We're pretty good about getting patients in a timely manner. We have same day appointment slots set up as well for those the acuity or urgent things as well. So having that flexibility with your schedule is I think the thing that makes it happen. So, and then be able to set up if like you said, you can only address a few things during that visit. I do something similar. You pick 2 and I'll pick 1. And if I say, let's see you back in 2 weeks and we can address the other things, we'll do that as well.
As long as you have the capacity in 2 weeks, then it works. Yep.
And again, I control my schedule, so makes it a lot easier. I also, in spite of the fact I'm a specialist, I do actually have people I see more than once a year. And so the rapport with the patient, I know what's coming. I know that this guy I'm going to feel like I've had a bone marrow biopsy when I get done seeing him. And so I a lot more time. And the other one that resonated, I think, with a couple people here. That's how I do it. I know what's coming for the most part. And I try to give them as much time as they need.
Well, we have run the gamut through erectile dysfunction, fatigue, hormonal imbalance, testosterone issues, PSA and prostate issues, mental health, and Dr. Google. So it's been a great discussion. I want to thank you all again so much. Apologies to Florida. And we really appreciate your time. And I hope everyone enjoyed themselves tonight. Thank you. Thank you so much for coming.
Thank you.